they didn't want to sacrifice benefit whatsoever. And so making sure that we were keeping same or similar deductible levels. And we actually ended up enhancing their plan and adding some co-pays to their plan. So that was definitely a win from what we were expecting versus even their worst case scenario from an aggregate standpoint. There was savings, so they love, that they were able to achieve some savings no matter what. And so there was some savings on the table, and then we even, enhanced their plan even further and added a $0 tier for not only HELPcare clinic as a preferred provider, but other specialties across Minnesota, Wisconsin, Iowa, so that people can get to the highest quality, lowest cost option and not have any out-of-pocket costs. And so we're starting to get a lot of positive feedback from the membership that, hey, our interactions with HELPcare has been great. Their team's awesome. The nurse navigator that we work with, Nurse Sarah, is awesome. They're timely, they're helpful, and the cherry on top is I didn't have to pay anything when I went to the doctor.
Hey, welcome to Take Charge with HELPcare. We're excited to kick off Season 2. Dan Hinmon, my co-host, and I are with a guest that was with us for a couple of episodes last year. Colton Storla is with North Risk Partners, and I've had an opportunity to work with Colton for almost 3 years now. And so we're excited to have him back to update us on a story that we shared last year about how we put together the health plan for Mower County employees and their dependents. So, Colton, welcome back to Take Charge with HELPcare. I'd love to have you
Thanks for
introduce
having me.
yourself, briefly, and kind of what makes you tick, and then we'll get into some of the, what's actually happened since we've been able to work together.
Yeah, thanks again for having me. It's crazy to think that it's already almost been 3 years.
Yeah.
Time flies. But Colton Storla, I am the Vice President of Employee Benefits at North Risk Partners. And so, my day-to-day is, working with employers on their employee benefits program. But I tend to spend a lot of time on the healthcare and health insurance consulting side of things. And so that spends a lot of time because it's a big expense. It's a challenging expense to try and tackle, but it's meaningful if we can truly, make some of these wavelengths and what we're trying to do in some of these health plans.
So 2 years ago, right now, we were kind of in the throes of meeting with the county leadership, with the employee benefits committee, and kind of putting together a different plan. What was the situation that the county was looking at in terms of what their plan was at that time, and then what their renewal was looking like it was going to be?
Yeah, I feel like, kind of digging back into the file cabinet of some of the concerns, I felt like, their leadership was saying that we were getting big increases. We really weren't getting any true data, hard data on why we were getting increases, regardless of what they were being told their loss ratio was, whether it was by their brokers or their carrier. And so that can, make anybody frustrated. Why are things going up? We feel like we're, doing all the right things and so on and so forth. And so, we took them through an exercise of just looking at their claims and their contracts and just really did an analysis of what the opportunities could be if we were to go to more of a self-funded model and get complete transparency and control, as well as, cost containment programs, whether that's through direct primary care with HELPcare Clinic, some of the pharmacy programs, navigation to high quality, low cost providers, and simply, trying to create a win-win situation between the health plan and its members. Because what we like to do is build these mutually beneficial arrangements between the health plan that if the health plan is going to save money, we want the members to save money too, and create those incentives so that everybody wins. There's too many employees that I feel like as their employers are making decisions on their health plan, they always think that the employers are making decisions for their own benefit or their own bottom line, but they were, clear on making sure that, hey, we don't just want to jump ship for our behalf. We want to make sure that it's good for our entire team, especially being a government entity. They recruit and retain based off their benefit programs. It's a big chunk of their total compensation. So they flat out said that, hey, if you got something better and it's going to save us money, we're ready for it. And so we went through a series of education sessions, not only with the leadership, but the insurance committee, and just trying to get people up to speed on what else is out there because it is a complex world we live in health insurance and healthcare. And so it does take a little bit of education, but it's truly meaningful the more people know about what's going on, really behind the scenes.
So what were some of the pieces that were part of the plan and some of the changes that you were able to introduce?
Yeah, so first thing that we identified was that they were in, kind of a pooled plan with other employers with a big name insurance carrier. And behind the scenes, it kind of ran like a quasi self-funded plan, but they weren't truly getting the benefits of being self-funded. Again, limited data, limited customization, and they could have even been in the situation where they were, offsetting some of the costs of some of the other groups in that pool of employers. And so we took them to an independent TPA. We looked at, a PPO network so they can still maintain access to, Mayo Clinic, for example. That's everybody's biggest concern is, am I still going to be able to go to my doctor? Can I go to the hospitals that I want to? So we were able to check some of those boxes. And then just looking at the pharmacy piece, that's a piece that's, top of mind of every employer right now. New innovations, new drugs come in the marketplace. They come with pretty hefty price tags. So making sure that we're working with a fiduciary, a PBM, or pharmacy benefit manager to make sure that they're, trying to go after lowest net cost on drugs and taking into account rebates, making sure those rebates are going back to the group and not being kept by the insurance carrier or the pharmacy benefit manager. And then even throwing some additional solutions at it, cash pay for, certain medications, discount programs, Mark Cuban's cost plus drugs, and other programs to try and reduce those pharmacy costs and just manage that pharmacy supply chain.
So what's the role of direct primary care in a plan like this as you're putting it together?
Yeah, that's definitely a foundational piece along with the nurse navigator. We want to make sure that the direct primary care with your services, HELPcare clinic, that's kind of the front door to the health plan or seeking healthcare services out of any member. I always like to tell employers that, we're giving our employees an unlimited credit card and they don't know cost, they don't know quality, and just healthcare happens. And sometimes people can find themselves, going to the wrong place right from the get-go, or going to a very expensive place, or just going through all the hoops of healthcare and being referred and referred and referred. And it's just easier to start with a primary care doctor that knows you, knows your medical history, and then can put together a plan. And maybe they even just take care of you because they have the time, they have the expertise. But if not, obviously we have a great workflow with you and your team that if we need to refer externally, we've got preferred providers, we've got nurse navigators that can help direct that member so that they're not caught in limbo, not knowing what to do. And that way, they're starting with the direct primary care. And then if they need to, seek services externally, we're getting to the highest quality, lowest cost option.
Yeah, I think that's part of the distinction between direct primary care and sort of hospital-based primary care is that with hospital-based primary care, they're typically going to be doing referrals to other specialists because that's part of their whole model. That's how they work. And the primary care practitioners just don't have that time to be able to dig into all that. Whereas with direct primary care, the whole idea is to do as much as we can, possibly. Like if it's a service that could be provided at the primary care level, you want to do it. And for one thing, you're doing it right then. Like you're able to provide the more immediate relief. But then, and so there isn't the waiting for the specialist referral and all that. But there's also not the extra charge that comes
Yep.
from from going to a
Just
specialist too.
removing the friction and the financial piece. I truly believe removing those financial barriers to care for people is super impactful because we even see it in some of their, data on they use a telemedicine company and they always ask the question after each visit, where would you have gone if you didn't have this benefit? And a lot of the responses were, I wouldn't have gone,
Mhm.
which then that can turn into, other major things if people are just saying, well, I'll wait a week or I'll get around to it. And that can turn into, bigger things. And so just removing that financial barrier to care is super important. And then even just hearing from the members that have experienced, going to the big health system in their neck of the woods. It takes a while to get in. Sometimes, they have to go in for their labs for one visit and then they got to schedule a different visit for the actual, consultation with the primary care. So now it's double the time away, and it's expensive. And so again, just reducing that friction, streamlining it, makes it, awesome for, the member experience.
Yeah, also just say that for the practitioners that I work with as part of healthcare clinic, they find it a lot more satisfying too when they can actually solve problems and they can actually deal with the issue instead of only referring. Like there's sometimes when it's not something they can do, but being able to kind of reach back and dig deeper into their toolkit and try some different things that they maybe wouldn't be able to do in a 7-minute, 10-minute office visit treadmill.
And surprise, surprise, that's probably why they went to, medical school.
Yeah.
Because they want to help people, not just
Exactly.
refer people.
Yeah.
They want to make a difference. They want to cultivate those relationships and, just get people healthy. And that's what I tell employers too. It's like we've got a lot of tools in our toolbox that we can reduce the unit cost of your, MRI, your surgery, your oncology treatments, your whatever. But there's a point where we can only reduce the cost so much where now we just need to double down on population health and just get people healthy so we don't have to worry about, lowering that unit cost.
So, Colton, you started by explaining what Mower County was facing a year and a half or 2 years ago, the reason why they brought you and also Lee into the formula. So, what did that plan end up doing for their members?
Yeah. Well, like I said, they didn't want to sacrifice benefit whatsoever. And so making sure that we were keeping same or similar deductible levels. And we actually ended up enhancing their plan and adding some co-pays to their plan. So that was definitely a win from what we were expecting versus even their worst case scenario from an aggregate standpoint. There was savings, so they love, that they were able to achieve some savings no matter what. And so there was some savings on the table, and then we even, enhanced their plan even further and added a $0 tier for not only healthcare clinic as a preferred provider, but other specialties across Minnesota, Wisconsin, Iowa, so that people can get to the highest quality, lowest cost option and not have any out-of-pocket costs. And so we're starting to get a lot of positive feedback from the membership that, hey, our interactions with healthcare has been great. Their team's awesome. The nurse navigator that we work with, Nurse Sarah, is awesome. They're timely, they're helpful, and the cherry on top is I didn't have to pay anything when I went to the doctor.
I'm sure the members love that.
Yep.
Not less money out of pocket. And so, what about the big picture? How did their cost change as an organization from before and after? Do you have some insights on that as well?
Yeah, a lot of times what we do is we look at their medical spend, their pharmacy spend, and they were able to lower their medical and pharmacy spend by almost 7%. Meanwhile, how, other groups are seeing high single, if not double digit increases on medical trend, not only what the risk within their population, but also just medical trend in general. So they're kind of fighting two different evils there. But we were able to achieve, lower claim volume, which is good because then you see better renewals, which we did in 2026. The plan functioned the way it was supposed to. There's always areas for improvement. We want more people to engage with the nurse navigators. We want more people to engage with the direct primary care doctors. But we made a good, first step being into the plan for the first year. So they were able to, I think guaranteed savings was right around a $500,000, and they're kind of right on target for that. We're settling up their accounts, and even when they saw, one high cost claimant in 2025, it didn't completely turn their plan upside down. The stop loss did exactly what it was supposed to do, and they were able to renew with a low single-digit increase. And so we're just going to continue to educate and keep this momentum with the employees now that we're starting to get. The first year you get this skepticism that it's, too good to be true. What do you mean it's free? And, we have a nurse navigator, that's different. And people are just skeptical to using those things. But now we're seeing that, water cooler talk that's happening like, hey, it's exactly what they say it is. Use HELPcare Clinic, use the nurse navigators, and they're there to help you. And it's not only going to help you from a healthcare perspective, but from a financial perspective. So, one other thing that I looked at as well was just looking at high cost claims, and usually that may be claims over $10,000, $25,000, $50,000. Looking back at some of their claims reports back, when we started engaging with them and looking at that, I think they had over like 30 some high cost claims, and last year we only saw 10. And so that's a huge win too, because managing high cost claims is very difficult to do. But if we can get that figured out, it really helps from an overall, renewal aspect, because stop loss carriers don't like to see high cost claims. But since people are engaging with the programs the way they're supposed to, I think that's, part of the reason why we saw less high cost claims entering the plan too.
That was going to be my question. Why did it drop, do you think, so much from 50 to what it was? You started by answering it a little bit, that people are engaged more in the program, you think?
Yep, absolutely.
That means that they're seeing a healthcare clinic provider more often or sooner than they would maybe have otherwise. Do you think that's part of it?
Yeah, absolutely. With any given health plan that's ACA compliant, preventative, care is covered at 100%. Yet we see, less than 20% of people that even, exercise that right. And that's just due to, the friction that they experience trying to get into a doctor, the financial impact, even though we're telling the membership that it's free and included. A lot of times they're getting hit with surprise bills because they started talking about something that was more diagnostic, or they added an additional lab that wasn't considered preventative. And so we saw pretty close to 50% engagement with HELPcare Clinic
Wow.
during that first year, which is great, because that could have been, a lot of people that avoided the doctor, but they didn't. And I applaud the county's leadership too, because they gave everybody, PTO to schedule their first visit. And that's a super important piece, is that we have buy-in from the leadership team to engage in these programs, because it's one thing to, say, hey, yeah, we want to do the program, we want to save money, but then when the rubber meets the road and they don't make it easy for people to use preferred providers or go to their DPC, then it's just not going to work. And I think they're understanding the ROI of, how important it is for people to get that first visit, get to know their doctor. That way that barriers now, dropped, and people just are, just going into the doctor in the future as things come up.
Yeah, so it's one thing to get them to the first appointment, but it's another thing to have them love it and keep coming back, right?
Yep,
So,
absolutely.
so you're saying that overall you're hearing that the members were really pleased with their healthcare experience. Any anecdotal? I mean, it's probably anecdotal, but I mean, Lee or Colton, any stories? Anybody say something about how much they're really enjoying that quality of care and personalization they're getting at Help?
Well, I think one story that jumps out at me, Lee, is when we did kind of a mid-year check-in education session, that we had a member kind of raise their hand and say, I was one of those high-cost claims. And I was going to the big health system, and it was a very expensive drug, and it was an office visit, and she had to take time away from work to get that injection. We worked with Lee and their team and the nurse navigators where we could just have the drug administered in HELPcare clinic, which was just right around the corner from
Mhm.
work. And so she didn't really have to take much time off of work. She saved money, the health plan saved money, and she loves Dr. Strobel.
Yeah. Yeah, I mean, it was a very expensive drug that just became kind of expensive. Like it was still an expensive drug. It was still, $20,000 plus for the injection, but versus, 60,000 to have it done in the hospital setting essentially. So yeah, she was happy to volunteer it, and her coworkers were about ready to like put her up on their shoulders and say, and carry her around to say, hey, this is exactly what we're all about here, is to work together and find ways that we can save, and it's just better for everybody.
Great story.
So, Colton, you were, we talked about there was one pretty high cost claim over $1 million. And I can, when you're talking about a self-funded versus a fully insured, maybe you can talk about the distinction between those and why, some people, some employers might be a little hesitant because it's like, what if we have one of those big claims or a couple of those? Is that going to totally wreck us? How do
Yeah.
you set up a plan so that even, you don't have to have 300 employees to have a plan like this that can work? It can be 25, 50, even lower than that sometimes.
Yeah, sometimes, when we use the word self-funding, employers think that they're just going to have to pay all their claims and they're writing checks or you swiping their credit card. And, for most groups, they're not completely self-funded. They are purchasing stop loss to cover the catastrophic. And so, like I said, the stop loss, worked exactly how it was supposed to. The county was, paying their portion, but then, over that specific deductible, the stop loss stepped in and paid, their portion too. And so that is, an employer's number one concern. Well, what if we do have a high cost claim? Is that just going to completely wreck us and turn our plan upside down? And it's like, well, I ask, well, what happens now? Even in like a fully insured environment, your costs are going up because of that high cost claim. So you're at least when you're in a self-funded arrangement, you have the information, you have a potential strategy that, hey, we're seeing this high cost claim come through. How can we help this member either go to a preferred provider, trying to navigate patients to other sites of service? And there's all these, unique things that you can do, even ongoing to try and help the member, help the plan. So that way you're not dealing with, increasing, renewals like you would on a fully insured basis. So I always say if there's a will, there's a way, because we have a lot of unique programs from, MSK to cardiovascular to cancer, all those big ticket items that we see in a health plan that we can do what we can to not only help the member but also mitigate that high cost claim that hits the plan. And sometimes there are things that are out of our control and we just have to roll with the punches, and there's always different strategies that we can position in the future.
You talked about how, information is essential, like getting the data, finding out what's going on so you can actually take some action. On a macro level, we're talking about how knowledge is power too, and we're having an event coming up in August 5th in Rochester. You're the chapter co-leader for the Iowa chapter of the Free Market Medical Association. I'm a chapter co-leader in the Minnesota chapter, and we're kind of combining to be able to do this event in Rochester where we're going to go through, some of these pieces that are part of putting together a plan where the employers can actually take charge of their health plan, building a better employer health plan. Tell us a little bit about what we can expect or what people can expect if they come in, and who's this event for? Who's the best person to come to this?
Yeah, obviously employers, CEOs, CFOs, HR leaders that are in these, benefit decision-making roles. We purely just want to make it educational. We're also inviting other, individuals from the healthcare community, like Active PT and others, because this truly is a group effort, and it takes education. Like I said, we live in a complex world of healthcare and insurance, and we just want to be as educational as possible. So whether people work with us in the end of it or not, they're gonna, walk away with little nuggets of information that they can take back to, their leadership, their advisors, and something that they can hopefully build on in the future when the time is right.
So when someone goes to a self-funded health plan, is it guaranteed that they're going to save money?
It's not always guaranteed, but what I like to say is, there's a right way and a wrong way to self-fund, and it's just again an education aspect. Just learning about stop loss. I talked to a CFO recently that he's looking at going self-funded, and just the stop loss piece is kind of has him perplexed. And so I kind of took him through the different contracts from 1212 to 1215, 1218, the more aggressive approach versus conservative approach. But self-funding is just really served to be as kind of a tool for transparency, control, and it's what you can do while you're self-funded to reduce the frequency and severity of claims. We've even been in situations where we like to educate employers to not think about self-funding 12 months at a time, because obviously that's when renewals usually happen, and you really need to look out, 2, 3, 5 years and build a business plan that's okay. Let's take you to self-funding. Let's, take a very conservative approach to it and then really build on it, adding direct primary care, adding nurse navigation, doing some of these pharmacy programs that over time, your cost curve is just going to start to flatten, a lot, in your favor versus just doing nothing.
Yeah. Well, there's no guarantee, but there's kind of a negative guarantee if you stay with the fully insured, is that they're like, if you never do anything different, if you never put in any of these tools that give you a chance to potentially, lower some of those costs, there's no reason to expect that anything other than what you've had up to now is gonna
Yeah.
happen.
Yeah, I mean, a telling question is you can just ask, the employer, the carrier that you're working with, do you think they benefit by raising your costs or lowering your costs? And of course, they usually smile and say, when our costs go up, and it's like, well, that's exactly right. And usually they're not giving you many tools in the toolbox to reduce your claims to then reduce your premiums.
Talk a little bit about the medical loss ratio that was part of the Affordable Care Act and what effect that's had on premiums.
Yeah, so that was a thing that was written into the Affordable Care Act, medical loss ratio, and I think, it was a good idea
It was a
right from the
well-intended idea
it was
anyway.
yeah, it was an well-intended idea that, depending upon your group size, that for every dollar that you pay in insurance premiums, 80 to 85% of that has to go towards paying claims. So that really capped the health insurance carrier's profitability at that 15 to 20%. But what we know and what I like to joke is, health insurance carriers aren't stupid and they operate like casinos. The house always wins. So they really look at that, how can we grow that 15 or 20%? Well, we need to inflate claims or, increase premiums to increase our share of that. And on the flip side, a lot of these big health insurance carriers, they own the networks, they own the TPAs, they own the insurance portion, they own the pharmacy benefit managers, they own every piece of the pie. So not only are they making money off that 15 to 20% that they're capped at, but they're also making money on all of your claims. So it's almost like a double dipping effect. And so that's another way to help combat that is by going into a self-funded arrangement where you can control your own costs, your own destiny, and really try and tackle those claims because, yeah, the claims is what makes up a good chunk of your overall spend.
Yeah. Well, with that medical loss ratio that you're talking about, if you've got, if you think about primary care as basic maintenance kind of stuff, it's like your car insurance doesn't pay for wiper blades and tires and oil changes. This is sort of like that kind of care that for your body. And if you had somebody coming in and taking a 20% cut of all your car maintenance expenses, then that'd drive up those costs too. And so that's part of where direct primary care can be a lot better because we're not filing claims. We're not running through that money through the insurance company. And so that's just something right off the top that can help.
Yeah, we're truly trying to create as many direct pay relationships between the employer and healthcare providers in all situations because it's just the middlemen that seem to, charge a lot, take their cut off the top. So that's kind of the whole purpose of my own podcast and, Community Connected Health is, trying to connect the business community and their members to healthcare in their community and trying to create these direct pay relationships, remove the middlemen as much as possible. And I always say that there's, four buckets within your health plan. There's primary care, there is pharmacy, there's inpatient, and there's outpatient. There are tools and resources in each of those buckets that we can bring a solution to the table to try and reduce on the frequency and severity of claims in your plan. And that's just going to, lower your costs more and more. Or in your case, it's a capitated arrangement. It's a fixed cost and it's a known cost, and people can use it as much as they want, and the cost stays the same.
Yeah. Well, great. We're really excited about the event coming up on August 5th. So to encourage people who are wanting to dive deeper and learn more to come spend the afternoon with us in Rochester. It's 1 to 5 at the Haley Center, upstairs of the Haley Comfort Systems building in Rochester. We'll have links in the show notes, both to that event as well as also to the previous episodes that we've done with Colton. But I want to thank you, Colton, for joining. Thanks, Dan, for co-hosting and helping to help us clarify the communication and get the message out. So we're excited about what we can do together, and we really have appreciated working with you, Colton, and with your firm to help make this happen.
Yeah, no, appreciation to you and your team as well.
Thanks for joining us. If you enjoyed this episode, be sure to leave a comment or a review and to subscribe on Spotify, Apple Podcasts, or on YouTube. And also to share Take Charge with HELPcare with your friends and on your social media channels. At HELPcare, our passion is helping people take charge of their health and their health care, helping employers take charge of their health plan expenses, and helping physicians and other practitioners take charge of their healthcare careers. Learn more about the healthcare clinic difference at helpcare.health.